Hello?
Yes, sir.
Hello?
Hello, sir.
Are you getting anything on the screen?
Still picture we got.
Hello?
It's a
Are
still
you
picture,
getting
sir.
anything
Nothing
on
is
the
moving.
screen?
There is screen, sir, but still picture is there. Nothing is moving.
Is it going?
No,
Are
sir.
you getting MRI on the screen?
Yeah, yeah. Now it's moving. Yeah.
Yes. See now, this is normal fat suppress MRI where you see no enhancement, no abnormal enhancement anywhere. The fat is suppressed everywhere. Now, I am bringing normal T1 weighted MRI. See this. T1 will show wherever the fat is enhancing. See now, the fat in the cheek. See, classically the fat in the upper alveolus. This is the bone marrow of the upper alveolus, which is suppressed on T2 fat suppressed. Now, if on T2 fat suppressed there is no enhancement, and if there is enhancement, that is inflammation. Suspecting mucor means here the mucor has invaded the alveolus. That is what you can pick up. Now see how to see the for the pterygoid bone involvement. See this. See the pterygoid process on both sides with the bone marrow. See the bone marrow. In a normal situation, you will find this bone marrow. This is T1. This is fat, which is enhancing the marrow fat. On T2 weighted, it is. See, this is dark signal because the fat is suppressed. Got my point? Now, whenever on T2 weighted fat suppressed, you find any enhancement, that means that is inflammation. That is what I wanted to tell you. Now, I'll give you a couple of examples, you know, where you can see easily now on fat suppressed. Easily, see this patient, T2 weighted. See this. What is there in the alveolus and palate? Hello? See the inflammation. See the inflammation, and if you bring the T1 weighted together, you will see. See the marrow on the normal side? Can you see the marrow on T1? Hello?
Yes, sir.
Normal marrow on T1 and the opposite side marrow is replaced by infection, which you see here as a hyperintensity on T2. It confirms your diagnosis. You don't need anything else. It is so clear. It is so clear. And wherever there is necrotic bone, on contrast, if you see, you will not find any enhancement. Whenever there is necrotic bone, see this. This is necrotic bone here. See, no enhancement. This is necrotic bone because the contrast is not reaching there. And I tell you, in spite of being a medical disease, if mucor is there somewhere in the bone, palate, pterygoid, anywhere, any bone, there is no penetration of antifungal. If bone is involved, you have to remove it. If you miss the bony involvement without a good MRI, if you try to treat on the on the basis of CT scan, is a joke. You cannot pick up all these. All these sequences are not available on CT scan. A mucor cannot be properly treated. Simply cannot, in bold letters, on the basis of CT scan. You must have MRI, otherwise it's a joke. So, you see, wherever the bone involvement is, no antifungal, liposomal amphotericin B, anything is going to work. You have to see how the bone is involved. Now, MRI can pick up bone involvement very nice. I can show you massive, funny bone involvement. We had to remove the entire skull bone sometimes. See this patient. We had to remove a big part of the skull bone. And many of the patients, number of patients we removed. See this. See this. Normally, a normal bone is never enhancing. See, whatever it is, enhancing on contrast means involvement of this area, and this is necrotic also. But I said when bone is involved, even enhancing, you have to remove it because there is hardly any penetration of antifungal. So we had to remove this entire frontal bone. See this. See this much. This entire frontal bone had to be removed thoroughly. Otherwise, you cannot give a you know justification to such patients. See this. This patient you can never forget is still surviving. That poor patient had massive involvement. See this entire frontal bone right till even the almost going towards the vortex. This entire bone is destroyed by the yes external approach for such patient. Entire bone you have to you know remove. Otherwise, whatever antifungal you give is not going to work. So this is so important. Sometimes the fungus gives brain abscesses, and like this patient is still again surviving. But see, once there is an abscess, again, the antifungal do not work. See this, the brain abscess. See, the intranasal part was done by somebody. See, entire work is done. Good surgical work done. But you see what is happening? The brain abscess above. Not only here, there are multiple brain abscesses. See, brain abscess in the occipital region. And these are walled abscesses. Your antifungals are not going to penetrate. And amphotericin particularly has hardly any penetration, in the intracranial space. Very difficult, and such multiple brain abscesses. See this tentorial abscess. See this abscess above the posterior roof of the posterior sigmoid. These abscesses form when you find endoscopically your, the cribriform is necrose. That means you have to remove it, as otherwise this is going to lead to ascending infection above the layer. Many times you have seen the involvement of the carotid artery. The carotid artery involvement is one of the most massive involvement, I would say. And there are certain patients where you find the carotid involved, massive brain, infarctions because of this disease. This is so bad a disease because once it is so aggressive, it gives multiple infarctions in the brain. I'll give you other examples of, see this massive disseminated mucormycosis. These are the patients now where you have your limits of the treatment and they don't, see this massive disseminated entire eyeball, entire almost 75% of the face is affected right from the soft tissues outside. This is mucor with multiple brain abscesses. This is see multiple disseminated walled brain abscesses. You can't help. You can't see the entire sphenoid with carotid 360-degree carotid. Now this is your limitation. You can't treat such patients. These are most difficult disseminated fungal disease. This patient we had treated and we had to remove a lot of things in the this patient. I'll give you one example where this was involving the TM joint and we had to remove the TM joint. The orbital abscesses, multiple abscesses in the orbit, massive disease in the infratemporal fossa, massive multiple abscesses in the temporalis muscle, going all the way into the massive multiple abscesses in all the muscles of mastication. All muscles, ipsilateral muscles having multiple abscesses, and you have no option but to remove everything because no antifungal is going to work. So there are such, patients where those poor patients, they have to suffer. There is no answer to such problems. See this patient had multiple infarctions in the brain. This is FLAIR imaging showing infarctions. Multiple infarctions into the brain because of the carotid occlusion. I'll give you another example. So you have to be, cautious about such patients where the disseminated disease can lead to problems. And because being the nature of the disease, this spreads very fast. Now, this patient, see this, had because of the vasculitis, the mucor vasculitis, the carotid got blocked, completely blocked, had developed multiple infarctions. We have the angiogram also to show you. See this, first of all. That's the carotid artery on this side, and this carotid artery is a thrombus, not enhancing. This was a complete blockage of the carotid artery, which gave him problems. You see this. This is the carotid artery on this side. This is MR angiogram. That's the vertebral arteries on this side, both sides. This carotid artery. And this carotid artery had thrombus, completely, blocked. And ultimately, this patient developed a lot of infarctions in the brain and died. So there are variety of situations where this disease can present to different level. In the eye, there are patients where you can save the eye. There are patients where you need to, remove the eye. A lot of patients where we have given orbital clearance, having good vision or even the vision loss, yet we preserve the orbit. See, this patient had a lot of disease in the medial part of the orbit, but the vision was good, and we did the orbital clearance because the eyeball was not involved. If the eyeball is involved, you have to do exentration. See this. When the eyeball, anterior eyeball per se is involved, you have to exentrate. See this. See this. So anteriorly, the eyeball and surrounding tissue is involved with multiple abscesses. Then there is no point in preserving the orbit in such situation. You have to clear it completely. If you have a limited disease in the eye, you can clear it. But if there is massive disease, you have to remove it to save the patient, because saving patient is a priority. See this patient has a limited abscesses in the eye. Young chap, 32-year-old, limited abscess in the eye, vision was good. So we did endoscopic from the same field, went inside the orbit and did clearance. These two necrotic areas, these were necrotic areas, and the antifungal worked, and we could preserve the eye. So exentration is different, clearance is different, and this patient.
Sir,
See the
in
funny.
case of, excuse me, sir.
Yes,
Sir, in
please.
cases of limited disease in the orbit, if we remove the part of muscle and this thing, diplopia will be there, or movement of the eyeball will be hampered or no?
Yes, eyeball movement, yes, can hamper. But even if the vision is gone, if you are able to preserve the eye for the cosmetic purpose, it is good. If it is not involving the eyeball. See this patient, absolutely normal eyes on appearance, no paranasal sinus disease, hardly any paranasal sinus disease. This patient had presented with vision loss, mucormycosis, vision loss. And see what we observed. This is MR angiogram. This is carotid artery. Can you see the ophthalmic artery? Hello?
Yes, sir. Yes, sir.
Can you see the ophthalmic artery
it's
on this side?
It's enhancing.
Yes. And see on this side, the ophthalmic artery is thrombosed, and patient presented with vision loss.
It's not enhancing, yeah.
So sometimes you get no other finding, but your MRI can tell you what exactly is going on. So these are the patient. And another thing, sometimes patient present with disease, with little diminished vision or early vision loss. And how can you pick up? By means of, a good diffusion weighted imaging. See this patient. He presented with vision loss and presented to us in the evening, same day, and had an optic nerve infarct. Hardly any disease, very limited disease, yet presented with orbital involvement, preferential orbital involvement. See, this was the sinusitis and had infarct of the right optic nerve. In fact, very limited disease in the orbit. This one had infarct in the optic nerve. The infarct is best picked up by diffusion, and diffusion will tell you that this vision is not going to come back once infarct has involved the optic nerve. Optic nerve infarcts are irreversible. That's a part of the brain. Optic nerve is part of the brain. It's not like other nerves. part of the brain, prolongation of the brain tissue into the eye, and such, funny things you can pick up on MRI. So MRI in those situations is very, very useful. And we have cases ready. You want to see any more FESS, or do I come back there? Because a lot of people are leaving early, I came to know. So to show the post-operative management and the complication. Anything like the way you like.
So you can come here, sir.
Okay then.
Audience has to say. Want to see the case or?
One case you can show.
Okay, one side
One
I
normal
can.
case.
FESS, yeah.
One case they want, sir.
Just for the rehearsal, what we had done yesterday. Okay,
So which case is ready, sir, now?
the cases are ready. All 4 cases are going on simultaneously. We had 12 cases today, so we are finishing them.
ये चारों टेबल पर ये संदीप किया हुआ है अभी 2 पे अंदर पड़ा है 2 ये तो छोटा सा एक साइड हाँ किस पे करेगा ये कुछ अजय ने इसमें लिख दिए किससे कौन सा कराना है ठीक है अजय देख सकता
सर आदमी क्या? Hello.
Hello. Yes, sir.
So quickly, I'll show one side and then come over there. See this patient. Massive polyposis bilateral. Can you see?
Yes, sir. Hello. Yes, sir. We are seeing. This is pus, like.
Yeah, some discharge. See this big polyp occupying the entire nasal cavity. Same story on the opposite side, multiple polyps.
You haven't yet packed, sir, the nose, sir.
Pardon?
Nose is prepared with pack, or
No.
you want
No.
to do?
Now I'm
No.
preparing.
Yeah.
We never inject. It's a topical preparation only.
How many marrow cells are enough for a case?
So we cut 2 marrow cell and cut into different size 8 to 10 pieces.
8 to 10.
And the same marrow cell is used again and again during the surgery.
Okay.
Remove it, soak in saline, rinse it, squeeze it, dip in the same solution, saline, adrenaline, and use it again during